So it appears that you give anything before surgery and it appears to be helping surgeons. So just to bring your surgeon's perspective in the medical oncology field, and as surgeons what we are concerned about is that whatever medicine that you want to give, will it make our surgery more difficult? Will it make our job more difficult? And will it actually make our job even possible or not? So that is what the fear with any form of neoadjuvant therapy is. These slides were provided by AstraZeneca, so obviously there is the result is going to be in favor of surgeons. But the prime objective is to understand that if we give Neoadjuvant Durvalumab along with chemotherapy followed by Adjuvant Durvalumab in resectable NSCLC, what effect would it have on our surgical outcomes, and would we as surgeons be able to do the surgery as we would want to do? If you look at the trial, the AEGEAN trial, the Durva was given along with a platinum-based doublet versus placebo in resectable NSCLC stage 2A to 3B. It included N2 disease as well, with both single session, multi-session N2. The surgery which was planned were lobectomy, stage resections or biolobectomy as per the initial imaging. There was no change in plan of surgery following the interval imaging. Obviously, all these tumors had to be no driver mutation, that is EGFR AL cross had to be negative. The primary endpoints were one, PCR by a defined central lab and event-free survival. Event being either progression of disease, which is not allowing surgery to happen, or intraoperatively if you find that there has been a progression which has been missed on imaging, which precludes surgery for us. So these were the two primary endpoints. The secondary endpoints being NPR, which is major pathological response showing less than 10% residual disease, and disease-free survival and overall survival. If we look at the primary endpoints, we see that the two curves showing the EFS were significantly separate. There was a hazard ratio of 0.68 with a p-value of 0.003, which showed that there was definite improvement in the event-free survival in the D arm. D arm is the Durvalumab arm, DPO is your placebo arm. More important than that, if we look at the PCR rates, there was a significant 13% absolute improvement in the PCR rates, which leads to a significant p-value of 0.000036%. Now, PCR rates might sound to be more of a pathological mark, but it makes a major difference for us as surgeons because it shows that the drug is actually acting and is helping you obviously shrink the tumor. But it's not important that it just shrinks the tumor, it also has to make it resectable in a way so that there are no adverse events and the surgery is not actually made difficult by it. And that is where the outcomes come in this. If you look at the baseline characters, the two groups are homogeneously matched. Actually, there is no major difference. In fact, the stratification was actually done both up to the T level and also on the basis of the PDL1 expression being less than 50% and more than 50%. On the right, left lower corner, you can see that regional lymph node, there were actually 10% of patients which had multi-station N2 also positive, which showed that this drug has actually taken into account not just the early cancers but also the medium level cancers where you find more N2 disease being positive, which can also be more representable in our type of patients that we have. If I look at the patients which had undergone surgery, almost a comparable number of patients in both the arms, 336 and 374, but more important is the next two figures, that of this 19.4% did not go surgery in the Durvalumab arm and 19.3 did not undergo surgery into the placebo arm. And if you look at the differences, you will realize that there was a more progression in the placebo arm and lesser in the Durvalumab arm. However, more patients became unfit for surgery because of probably Durvalumab as compared to patients in the placebo arm, which comes back to the fact that drug is not just making surgery easier. There might be lesser progression, but sometime it is also making surgery a little difficult by making the patient systemically unfit for surgery. Overall, almost comparable number of patients completed surgery, 77.6% in the Durvalumab arm and 76% in the placebo arm completed surgery, which shows that giving Durvalumab did not actually make any difference in our surgical outcomes. If you look at the time interval, there was no major delay in coming up for surgery. Patients came up almost at the same time for surgery with no major delays either in the placebo or the Durvalumab arm. The median time for delay in majority of the patients were less than 2 weeks, and most of the time it was logistical reasons, then adverse effects, which was the reason for not coming up for surgery. Again, a point in favor of the systemic therapy that we want to offer to the patients. If you look at the approach, we realize that there is no difference in the type of surgery that we are going to offer to the patient with or without the Durvalumab. In both the set of patients, there were equal number of patients undergoing minimal access as well as open surgery. Not just minimal access, but also the type of surgery that we are going to offer. Similar number of patients were able to offer lobectomy, as which was decided pre-operatively, and the same number of patients got pneumonectomy. In fact, if you look at the numerically, probably a better subset of patients were offered lobectomy as compared to pneumonectomy, and this was probably not just because of the type of drug which was given, but also because of the type of patient which was into it. Grossly, the aim of the publication was to look at the advantages rather than disadvantages of Durvalumab, and we can see that both the groups are evenly matched, and by giving the systemic therapy, it did not change our approach. Resection status, if you can see, again similar in terms. In fact, absolute status, if you look at head-to-head, the R1 resection was 4.2% versus 7.7% in the placebo arm, which shows that there was actually double the number of patients which are not offered, which were able to get a R1 resection in the placebo arm. No major adverse effects, 40% in the Durva arm, 39% in the placebo arm, again equal. No major surgical complications, in fact, again 59% in the Durva arm, 60% in the placebo arm, again almost equal number of patients, so nothing which is taking away surgery from us. In conclusion, regardless of disease state, the addition of perioperative Durva to neoadjuvant chemotherapy did not adversely impact the feasibility, type or approach or timing of surgery in patients with NSCLC. Thank you.